Since we are a small group, I think you can make it interactive or you can stop me anytime. This is a case of meningitis, but these days we cannot start without remembering what is happening in Sudan. So we can all make dua that the Sudan will be saved from this nasty war going on. And this is a case I have seen some time ago when I was in Riyadh Military Hospital. Edin asked me to introduce myself, but this is part of my area where I worked in a military hospital, but previously I worked in University of Khartoum for some time, and I was in United Kingdom for a bit of time. I was hoping that Dr. Abu Ubaida Hammour is around, so I can say I am 1 or 2 years ahead of him, so that will make me younger, right? I will not say when I did graduate, of course. In any case, this is a 27-year-old male who was presented to the hospital with occipital headache, neck pain, and photophobia with vomiting and blurred vision. Importantly, he did not have convulsions and he did not have loss of consciousness. And that was only for 3 days prior to presentation. In the past, he is known to have chronic renal failure with focal segmental glomerulosclerosis, and he had underwent an uneventful renal cadaveric, or now we can say deceased renal transplant in July 2008. At the time he came to the hospital, he was on tacrolimus, mycophenolate, and prednisolone. He is married and have 1 daughter. The examination was essentially normal. He's fully conscious oriented, his vitals were stable, and in particular, his CNS is normal higher functions, no meningeal irritation signs, and fundi were normal. I'm not sure if I can't see any juniors in the group, so we can have discussed a few issues, but anyway, the CBC and the urine electrolytes were all normal. So a blood culture was collected and he was started on vancomycin, ceftriaxone, ampicillin, and acyclovir with dexamethasone, the usual cocktail. So I was going to discuss if there are some juniors about whether you want to do CT scan before doing lumbar puncture. If anyone wants to comment, you are welcome, but we didn't think, we thought he has to have a CT scan simply because he's an immunocompromised. But otherwise, there was no indication because he did not have any focal neurological signs. His sensorium was intact, he did not have a seizure, and his fundus did not show papilledema, the usual indications for doing a CT scan. So maybe in the recording, the juniors will look at these features prior to doing CT scan, because this is important in Sudan in particular, because CT scan is expensive and you have to have a lot of time to get it arranged and done, and that will waste a lot of time, delay the antibiotic, which is a very important measure in getting a good outcome in management of meningitis. So in this case, there was an indication because he's immunocompromised. So following the CT scan, there was no focal changes. So we had a lumbar puncture and that showed the low glucose. The protein is just highish and the cells were raised at only 34, but mainly polymorphs. And that makes it very significant as an acute bacterial meningitis. So interestingly, the culture showed Streptococcus bovis, which was fully sensitive. And that was exciting because it's not the usual organism we see in patients with meningitis, at least in acute community-acquired bacterial meningitis. So that raises the question is, why is Streptococcus bovis meningitis? Was there any underlying cause? Very good. Yes, Ahmed, you're quite right. So as Ahmed mentioned, we wanted to look for why he had this meningitis. So patient denied any GI symptoms except for on and off constipation. He had vague abdominal pain. His echo did not show any evidence of vegetations. We wanted to do a colonoscopy, but the patient was very difficult and the preparation was difficult as well. So it wasn't done at that time. 1 week after admission, he complained of repeated vomiting. He had mild epigastric pain. He had chronic constipation as well, which he mentioned later. And the surgeons reviewed him, soft, non-tender abdomen, and his bowel sounds were okay. And this is his plain X-ray of the abdomen, which have showed gross dissection of the intestine. But as you could see, there are no fluid levels or any features to suggest mechanical intestinal obstruction. Am I going fast as the Edin, or we are going okay? So a diagnosis at time was subacute intestinal obstruction. So he went on conservative treatment. He improved. By then he completed 2 weeks of antibiotics, and he was discharged home with plans for OPD GI studies to find out why he had this bovis. As Ahmed mentioned earlier, that we have to look for a gastrointestinal focus. And this is Khartoum. It's sad to see what is happening now in Khartoum, actually. But we will hope in the future we'll have it more beautiful than this. And that's possible. We have the experience of Rwanda, and I'm sure you people will make it even looks much better. Bismillah. So he came again after discharge with occipital headache. He had vomiting, he had neck pain. There was fever, but this time he did not have photophobia. He was febrile, tachycardic. The rest of the examination is normal, and again, he did not have any meningeal irritation signs similar to his initial admission. The CBC, as you can see, now he became anemic. His hemoglobin dropped to 10. His other indices were normal, and his renal function is still intact. So we did a number puncture again, and you can see the glucose is low, the protein is higher than the previous admission, and the cell count even is higher this time. It's getting to 320 instead of 34. Again, it is polymorph with 97% and negative cryptococcal and other infections. So the problem now we are facing is relapsing Streptococcus bovis meningitis. Although his organism was sensitive, he had 2 weeks of treatment. Are we looking for a persistent GI pathology causing the bacteremia and meningitis? Or in some cases of recurrent meningitis, there may be a defect in the base of the skull. And again, bovis is not a usual organism to cause recurrent meningitis due to rhinorrhea and CSF leakage. And the other thing is a complement deficiency, which is again is seen more of meningococcal Neisseria meningitis rather than bovis. So we have to look for a cause for the recurrence. Now, the same thing, he started on the usual cocktail of vancomycin, ceftriaxone, ampicillin, but this time he's not an acyclovir because we know it is acute bacterial meningitis. So his meningitis symptoms improved in the hospital. He continued with diffuse abdominal pain. He had a weight loss of more than 10 kilograms. And as you can see from his CBC, he has dropped his hemoglobin to 8.6. His platelets are going on the high. His CBC otherwise showed some degree of eosinophilia, and his albumin is getting low. Any suggestions at this stage? We're becoming more wise this time. We repeated his LP while he's in hospital, and we can clearly see that he recovered his measures on the CSF examination. His glucose is being normal now. His protein has come down, and his cells are down from 320 to 2. So definitely he's responding to the same antibiotic he received last time. So we cannot blame that the antibiotics were not working in the initial admission. So because of this weight loss, we did a lot of studies to look for any cause of the weight loss for the anemia. So we looked into his stool examination, that was normal. His HIV status was negative. His alpha-fetoprotein is slightly, or it is raised actually. We don't know how to explain it. His complement level again is normal. Examinations and investigations for celiac disease were negative. The only abnormal thing we noted is that his T4 was high, it's 26.7, our upper limit is 22, and his TSH is markedly low, indicating some degree of cytotoxicosis. Now, because of this, we went for a nuclear scan, thyroid scan, and it confirmed the low uptake in the thyroid scan and showed features to keeping with a sort of thyroiditis. So he had some sort of thyroiditis causing cytotoxicosis with a low uptake of the nuclear scan. And because he's an immunosuppressed renal transplant patient, we wanted to exclude lymphoma, especially had some degree of eosinophilia, some intestinal or gastrointestinal lymphoma like IPSID and others. But his CT scan of the chest and abdomen were normal with no evidence to suggest lymphoma or any other organomegaly. Now, while in hospital, he was fully awake and he's mobile, but he developed cough with yellowish sputum. There was no chest pain. His chest X-ray, as you could see, is relatively normal. There were few rhonchi on examination, but excitingly again, his sputum showed heavy growth of E. coli, something we don't usually see in patients with pneumonia. So what is going on? So to sum up that, this patient had Streptococcus bovis meningitis. Again, not only Streptococcus bovis meningitis, but recurrent meningitis, although we could not prove the second attack was bovis, but we suspect it is bovis. By the way, the microbiologists might not be happy with this, but now it is called Galolicticus. Ahmed, I didn't, let me see. I think there is a, there are some messages. I'm not sure about his EB virus, but there was nothing really to remember about it, Ahmed. But he had, as we mentioned, the strep bovis meningitis. He had a recurrent meningitis. He had E. coli tracheobronchitis. And he had subacute thyroiditis. And then he had subacute intestinal obstruction. And because of this anemia, we suspected he had a GI bleeding. And he had developed some degree of eosinophilia. So I think we just leave it for discussion. Edin, if you allow. Edin.
Yeah, everybody can
If
unmute
anybody would
himself.
like to raise any concern or any comments. So Ahmed, you were mentioning something about EBV virus. Okay.
You are unmuted.
Okay. So if there are no suggestions, we will move. The repeat of the CSF did not show any organism, Dr. Nidal, yeah. but particularly did not show bovis.
Getting the second.
Was he still febrile? Sorry.
Go ahead, what's that?
I was asking, sorry to interrupt. Was he still febrile this time, or his fever's resolved?
The second admission, he had fever, and he had symptoms of to suggest meningitis, yes.
But how long it takes for him to be afebrile with the same combination of antibiotic?
I would say in a short period,
Okay.
because we repeated his LP within 2 to 3 days of admission, just to get sure that he's responding. So, and as you could see from the repeat lumbar puncture, is almost normalized his lumbar puncture, suggesting he's responding to treatment.
Great, thanks.
Dr. Fatehi Ahmed is
okay.
suggesting strongly lights. Ahmed is on now. Okay.
Yeah,
that's a good possibility. Yes, Ahmed.
Yeah,
that's a good possibility. Yes.
And where is this case geographically?
And the case was in Riyadh, in Saudi Arabia. He's a Saudi patient.
Yeah, I think the combination of the eosinophilia, gram-negative in the sputum, strep bovis, the GI pathogen, and the CNS makes me concerned about the strong G, especially because he got Dex again when he came. So maybe that kind of is causing hyper syndrome in him.
Yeah, that's a good possibility, Dr. Ahmed, yes.
I second that, and also I remember the strep bovis was associated with, I think, GI malignancies.
Absolutely.
It wouldn't explain the eosinophilia, but I think something to keep in mind maybe when he's stable
to be honest, his initial presentation, his eosinophil was low. The eosinophilia developed while he was in hospital. So at that time, people were thinking could be drug-induced eosinophilia, drug reactions, or but obviously strongylosis is a good possibility. Lymphoma was raised because of the eosinophilia and immunosuppression. And as clearly mentioned now, GI malignancy should be ruled out in anybody with Streptococcus bovis, meningitis, or bacteremia, of course. Yes, definitely. Okay, we'll carry on. If no more suggestions, we can continue. Okay, so for this time, he had a lower GI endoscopy, trying to rule out any malignancy. Again, it was not an easy one, but it showed area of erosion and ulceration. The only way to have it done properly is to do it under general anesthesia, because the patient wasn't cooperative and it was very difficult, but it did show some ulcerations. Again, because of his anemia, an abdominal pain, he had an upper GI endoscopy, and as you might see, there are multiple ulcerations. There are multiple healed ulcers, and as well as fresh ulcers that are oozing both duodenal and other sites. But at the time of the endoscopy, there was no active bleeding. It's just another view showing the multiplicity of the ulcerations. So why should he have multiple ulcerations? Something we see with Zollinger, Ellison's, and other things, but he has nothing to suggest this. There are multiple ulcerations. Any comments? Ahmed, you said men as part of the thyroid and the others, right? I think his calcium was normal, if I remember very well. Yeah, that was normal. But there are multiple oozing ulcerations. So he had a histopathology, and what you want to bet what could be the histopathology showing?
How was his CMV status? I'm sure he probably had some testing.
Yes, his IgG was positive, but again, I think his CMV viral load was not really high. And that's important also. The viral inclusion bodies were not seen. Later on, we'll see in the biopsy whether they were seen or not. But that's interesting, yes. Very, very important, actually. Very important. So, right. No betting. There's no payment for the betting. It's free. Okay. We'll just move. Okay. So that's histopathology. Anybody want to comment on the histopathology? Or to suggest anything?
Is that a granuloma of some sort, like organizing something? Or is that just fibrous tissue?
Well, there are lots of cells to suggest a granuloma, but there are no.
Are there eggs there, like
They what? Sorry.
Are there eggs like hematobium? ولا شنو دي?
Yeah,
It looks like
interesting. Well, yes,
What?
that's interesting. Well, there are features, honestly, to suggest it might be like schistosome eggs.
Yeah.
Yeah. There are a few, especially like this one, Doctora. This might suggest like,
yes.
yeah.
Very impressive.
Somebody also mentioned something else I just missed. Osei, I think. Did you mention something?
I just think still about strongyloidosis. That's it, but obviously that's not typical.
Yeah. Well, you are insisting. Yeah, it is possible. So just to cut it short because of the time, we saw this. Osei or Ahmed. So actually, this is the strongyloides worm. This is the worm of strongyloides. So this patient has strongyloides, and this is a longitudinal cut. And what you are seeing on the other section that looks like the schistosoma was the transverse cut through the worm. So it is suspicious, really. So this is strongyloides hyperinfection syndrome. Causing
How was the identification made, if I may ask?
of the strongyloides?
Yeah.
Well, we have a very experienced pathologist from the worm. He was very able to look into the worm, and he's so confident this is a strongyloides. Yes.
Funny enough, it wasn't seen in the endoscopy.
Endoscopy? No, it's only the ulceration. It's too small to be seen on the endoscopy, actually.
They won't see them. Okay.
They are too small. Usually they are embedded in the tissue. They are embedded in the tissue, but nothing like recovering the worm itself. Okay. So, and that's another, this more clear cut. You can see the worm more distinct with the with the intestine and other features. So the final diagnosis, that is strongyloides stercoralis. And of course, with this presentation is strongyloides hyperinfection syndrome. So at the time, the ideal treatment, of course, is ivermectin, but it wasn't available to us. We started him on albendazole, and his symptoms really markedly improved. He started to gain weight, and he gained weight. He gained weight, and his renal function luckily got maintained, and his graft was functioning. That was a few years ago. But when I called about him the other day, his renal function started to deteriorate because he's been a long time on transplant. Any betting here? Any suggestion?
How did he acquire this?
That will come to discussed. We think he got it from the transplanted kidney.
How long
Anyway,
ago was his transplant again?
he was transplanted like a few years prior to the to acquiring his the strongyloides. But to be honest, we were not sure whether he got it through the kidney or not. We tried to trace the other kidney if somebody has developed the same symptoms. We couldn't trace the twin kidney. We were not able to see if he had any previous strongyloides screening. He didn't have, because the screening was not available. So we guess it might be, but you cannot be sure, definitely. He could have reactivated his own strongyloides. Having said that, it's not a common infection we're seeing there.
Yeah, I mean, usually with intense immunosuppression, I guess he risks the chance of reactivation. So
Absolutely.
you would assume that during the induction phase, you know, if it was already there, he could have activated it if he had any history of like febrile illness or something at the time.
Yeah, absolutely. But you can never be sure. But we do know that strongyloides can be transmitted in the transplanted organ. There are a lot of reports to show that strongyloides can go through any transplanted organ.
It's also recommended that any transplant patient, including bone marrow transplant, to have a baseline serology for strongyloidosis. That's the practice.
Yes.
And if that is positive, they will treat empirically before the transplant.
That's right. That's true. Absolutely.
Out of interest, Fatehi, what was his HTLV status?
What was his what, Zahir?
HTLV status.
Yeah, that's interesting. I don't think we had it in our hospital, Zahir, but this is a very important point, yes, because people with HTLV are at higher risk of developing strongyloides. That's true. Now, nobody want to bet on this map, on this photo. Any guess?
Jabal Marra, right?
Who said Jabal Marra?
Qusay.
Qusay. Have you been to Jabal Marra, Qusay?
No, that was my dream. It's still my dream.
Anybody of us who had been to Jabal Marra? If anybody been to Jabal Marra? I was very excited a few months ago. I went with my family to Niagara Falls. Beautiful. But do you think this image is less beautiful than Niagara Falls? This is Jabal Marra. See how beautiful our country is. This is a country to fight for, not to fight on, unfortunately. Plenty of good things to have. So this is Jabal Marra, actually. Okay. Now, if you allow, then we have a very short review. Are we okay with time, Edin?
You can go ahead.
How many minutes I have?
I think we can leave you maybe 5-10 minutes max, and then we can.
Okay. So I will just briefly mention about the significance of isolating Streptococcus galolecticus, now we can say. Its association with the strongyloides, we'll mention a brief comment. And we did a review on strongyloides in transplant patients in the Gulf area. And we want to say, can strongyloides be transmitted by the graft? The question just be raised. So Streptococcus bovis is associated with GI lesion, especially carcinoma colon, as has been mentioned before. And what is important, colonic neoplasia may follow years after presentation. So if you did an endoscopy or colonoscopy following a bovis bacteremia or endocarditis, a normal one does not exclude it, and patients should be put on follow-up programs because they may develop it later. Liver disease is known to be associated with strongyloides, And also strongylosis bacteriemia meningitis, as we have seen in this case, is a feature of, bovis is a feature of strongyloidosis. This is actually a case we have seen in our cardiac center, a patient who presented with Streptococcus bovis prosthetic valve endocarditis. She had no GI symptoms, a lady of above 70. And when we did the colonoscopy, a huge mass was found into the colon. So it is bovis is a predictor of gastrointestinal malignancy. Now, there are reports of bacterial complications, of Streptococcus bovis meningitis. There were few reports before our case, and there were actually fatal recurrent bacterial meningitis, again, similar to our case with the recurrence of meningitis. Now, how does it cause it? As you could imagine, there were intestinal ulcerations. Bacteria get carried on the strongyloides larvae and get into the blood. And the larvae also, if I could say, defecate the organism or the bacteria in the bloodstream, leading to bacteremia or meningitis or endocarditis, whatever it is. We think that this degree of bacteremia has caused the meningitis and the thyroiditis as well. So the thyroid was involved because of the carriage of the bacteria to the thyroid, and the pneumonia is also caused by, or it's not exactly pneumonia, but tracheobronchitis by E. coli was again secondary to the bacteria traveling with the strongyloides. Don't worry, I will not show any more of this, but I just want to say peculiar feature of strongyloides is that the larvae can develop into an infective larvae inside the human body. They don't need to mature into other organisms and keep repeating infections within the same host. And that's why bacteria, strongyloides can survive into the human body for ages or decades. Those of you who are practicing in the United Kingdom might remember, or I don't know whether it is still a practice, that anybody who had been to the Far East as a prisoner of war has to be screened for strongyloides before giving the steroids. That's been even for 30, 40 years. Now, the hyperinfection syndrome is seen more commonly with steroids. And it is suggested that steroids had an effect on this cycle I just showed. Because of steroids had an effect on here, some of the metabolites lead to more penetration of the strongyloides. It's seen more in renal transplant. It's not probably it's because there are more renal transplants than other transplants, but interestingly, it is rare with HIV. It's not commonly seen with HIV. And as been Zahir mentioned, is more with HTLV, right? Now, another feature is that it is rare with cyclosporin as compared to other immunosuppressive. The interesting thing about this syndrome is really fatal syndrome. 70–90% mortality is seen in such infection. The first early reports of strongyloides in the Gulf were from Kuwait. Patients, 3 kidney recipients in Kuwait developed strongyloides. One of the transplants, they were from the donors were 2, so the kidneys were 4. The recipients were 4. 3 of them developed the strongyloides. The 4th did not develop it because the patient was taking cyclosporin. So probably protected because of the cyclosporin. And all of the patients died of ARDS. So, and the graphs given to these 4 Kuwaiti patients were from donors from endemic areas. So suggesting that it could have been transmitted through the transplant, the transplanted organ. So this is just to more evidence for cyclosporin protection. And as you know, now we are moving away from cyclosporin to tacrolimus, so probably one would expect more cases of strongyloides. This is a review we made about all the cases of strongyloides in the Middle East. And I could see that there were about 12 cases reported by the time we made the report 2 years ago. And 50% of the patient died, actually, which is a very high mortality. Strongylosis HIV, it's not a common association as one would have expected. Younger people like me will remember in 1987, the CDC and the WHO removed strongyloids from the infections specific to HIV. Maybe this is because of the Th2 preservation in advanced HIV infection. But more interesting is that it's seen more with immune reconstitution syndrome than advanced immunosuppression. I mean, now there is no talk now which can finish without talking about COVID, but COVID brought strongyloids into the picture again. Patients with COVID, as you all know, had xenopenia, and that is one of the predisposing conditions to strongyloids. And following the recovery trial, many patients received dexamethasone high dose, and that was expected to increase the number of strongyloids patients. But on the other hand, there are people who had received ivermectin, which is probably going to be protective to such patients. These are the case reports of strongyloids in COVID patients. And if you can see, the country of origin of the patients is mainly from endemic regions. Majority of them were actually from Ecuador and others. So it is endemicity which is important. And this is a nice review about COVID and strongyloids, which has just been published like 2 months ago. And again, the same thing that the patient's country of birth is usually an endemic region. So you have to be careful when you treat such patients with steroids for COVID. That's the same thing. Now, just because of time, there are 3 ways of different ways of recovering strongyloids for screening. The stool examination is very poor actually in yielding strongyloids. You need up to 7 stools to get to a better isolation rate of. But the single stool examination is very poor predictor. They try to improve it with concentration techniques, with agar culture techniques, but it still is not a good yield. The immunological examinations, their sensitivity is variable, but again, specificity is low because of multiple parasitic infection, especially in endemic areas. And of course, they do not tell you whether it is an acute or a previous infection. And lately, there are the molecular techniques. So I think, as being mentioned, that patients should be screened before any transplant for strongyloids, but it is difficult, as you could see from the measures of isolation of the organism. Eosinophilia is not present persistently. Stool examination is not very sensitive, and it does not discriminate, as we mentioned, current or previous infection. So there were multiple suggestions. This is actually a table to show you how to screen patients for strongyloids, and this is based mainly on endemicity of the areas the patient coming from and the presence of eosinophilia. And you either go for screening, or in some areas, actually, they just go for a presumptive treatment, where you just, if you're thinking of it, you treat, but that's again had some difficulties. So this is a question to you to decide what to do actually to transplant and patients on steroids in Sudan, whether you should screen versus presumptive treatment, because there are a number of patients who are getting renal transplant in Sudan now. We have COVID patients who had been treated with steroids, and we don't know whether we are still having more. And there are a lot of rheumatological patients who are taking steroids. So it is open to you to decide whether how to screen or to treat. Thank you so much. And if you have any comments or any
How endemic is strongy in Sudan? Anybody?
I tried to look, Yasser, into this, but I couldn't see really any studies. There was one case, I think, reported in one of the studies, but I guess it should be there because the refugees who came to Europe and the United States, if you remember the Lost Boys before, uh, when they were screened, there was about 25% of strongyloides. But having said that, it could have been done serology and there might be cross-reactivity with other organs, but I guess it will be there.
Thank you.
Thank you, Fatehi, for the very interesting presentation. Just a comment about the observation that cyclosporin A was found to be protective against mortality in this cluster of transplant recipients with strongyloides hyperinfection. This takes me back to the earlier point about association between HTLV and strongyloides hyperinfection syndrome. Cyclosporin A is actually a treatment for HTLV. It's called anti-HTLV activity. So in the early days, people were treated with cerevodine or cyclosporin A. And obviously, when the integrase inhibitors were launched, those two became maybe a thing of the past. So my question, do you know about anything about the HTLV serostatus of those recipients in Kuwait and others? I think you mentioned earlier.
I don't remember, but what I can do, I will go back to the papers. These are papers mentioned in the 90s, I think. So I will go and read them more in depth and see if there is anything. I will update you on the group.
Share them with us. That will be useful because I think it's intriguing that cyclosporin A has got anti-HTLV activity. Surprisingly, but as you said, there's now a move away from cyclosporin A to tacrolimus. So
that's right.
Effectiveness will be lost over time. But I think it goes back to the earlier point of screening for HTLV infection, and also, as you said, either giving presumptive treatment for strongyloidiasis or screening. I think with that situation, I think I'll just give presumptive treatment. That's entirely acceptable. Ivermectin is very cheap, has virtually no side effects. So
that's true. Yeah, that's interesting. I mean, the treatment is actually ivermectin. It could be single dose, a few days of treatment. Ivermectin should be okay. I mean, I remember for this patient, I have to borrow a few ivermectin tablets from Sudan because, we have the onchocercasis program going on. Ivermectin was not registered in Saudi Arabia, so I have to give it under the table,
Yeah. We have it here in Abu Dhabi, and we usually give 2 doses, one at baseline and then 2 weeks later to prevent the O2 reinfection, as you know, as a cycle.
Yeah. Because albendazole is not really very effective. So the people who are pro presumptive treatment, as Zahir, you mentioned, that it is a simple treatment. It's a very cheap drug. You can give it to whoever you think is. In developed countries, ivermectin accessibility is not as easy. And people were worried that if you give it a presumptive, they may run short of ivermectin. But maybe now with COVID, there may be more ivermectin in the market. But it is a possibility just to treat because the screening is difficult. And doing serology is not an easy thing. And not all the serological tests are very reliable, actually.
In my experience, testing is sometimes expensive or not affordable by patients. And therefore, what do? You just give them treatment and then take it from there. I think treatment is much cheaper than the testing itself.
Yeah, treatment is cheaper. The serology is expensive. Yeah. We actually, following these cases, try to do study of screening all the recipients of transplants, and then we wanted to screen to do serology for all the patients or deceased donors because we have their blood stored in the bank, but we were just stopped because of the cost of the serology. We did a number of them.